Well, good afternoon, everybody. Welcome. I'm Dr. Sandra Hernandez, and I'm the President and the CEO of the California Healthcare Foundation. And on behalf of the Foundation, I want to welcome all of you here today. The Foundation is an independent philanthropy working to improve healthcare throughout the state of California with a particular focus on low-income communities. We sponsor a number of Sacramento briefings to bring together policymakers and staff in Sacramento and other interested parties to really cover a number of issues, to inform on emerging trends, to bring data and evidence to problems that the state might be working on. And today's briefing, I think, is an extraordinary opportunity where we have the opportunity to hear from government agencies who have been working in a tremendous partnership over a number of years to address the extraordinary opioid epidemic that we're facing both in California and more broadly in the country. In addition to all of you in the room today, there's another 250 people that are signed up via a webinar, a statement of how impressive our panel and our speakers are today, but also how important the topic is. The opioid epidemic is, of course, the defining healthcare crisis of our time. Throughout California, our healthcare providers, our health plans, law enforcement, clinicians, physicians, patients, and families are all working in their own ways to respond to this extraordinary problem. We're seeing action both at the local level and at the state level, and in a state as diverse as ours, there are places where the opioid epidemic is reasonably contained and yet areas in the state where there's extraordinary work yet to be done. That said, we are starting to see enormous progress and some very early successes, which we'll try and share with you today. Today's briefing will examine the role of state agencies in combating the epidemic. You'll hear different collaborative approaches, including promoting safer prescribing practices, expanding access to medication-assisted treatment, and improving communications between prescribers, providers, and patients as well. Dr. Kelly Pfeifer, who leads our high-value care team at the Foundation and also our opioid safety program, will be giving you an overview of the epidemic and share some recent data and evidence. She'll then moderate a discussion between state agencies to further examine the work each agency has underway. After the moderated conversation, we'll take questions from the audience. Please join me in welcoming Kelly Pfeifer to the podium.
Thank you, Sandra. It's such an honor to be here with such a distinguished panelist. And I wanted to, as I mentioned, as Sandra mentioned, I'm going to be giving an overview of the epidemic, and then we'll get started for a really exciting discussion. The opioid epidemic is a story of many kinds of pain, and the well-intended but ultimately misguided efforts to kill pain that led to killing people instead. The Stat News did an incredible and compelling series on the epidemic, 52 weeks, 52 faces, 52 obituaries. And one of the most striking things about looking at the sea of faces is their youth. These are people in their 20s and early middle age, because although alcohol and tobacco kill far more people than opioids, neither smoking or drinking is likely to kill you tonight. And that's the tragedy of the opioid epidemic, because people are robbed of decades of their life. Could be a teenager experimenting with pills for the first time, a young adult in their first year of their addiction, or someone in middle age with chronic pain taking their drugs as their doctor prescribes. It might make a mistake, because it's hard to know when an 80 milligram Oxycontin is the size of a baby aspirin, that one tiny pill is the equivalent of 24 Norco. So a glass of wine and accidentally taking an extra pill can be a fatal mistake. So this is a very complex problem to solve. It may have started in the healthcare system, but it can't be solved by healthcare alone. But in California, we have real reason to be optimistic. Although in the U.S., 50,000 people have died in the last year, and we expect another 500,000 deaths in the next decade unless things change dramatically, California actually looks good on average. We have held our death rate stable for the last 2 years, which says a lot given the death rates continue to rise across the U.S. And when you look at the California average, Our total opioid deaths for 2015 were only 4.9 per 100,000, where the rest of the U.S. had double that at 10.4. But the average California story is a little misleading because we're such a large and complex state. So if you were going to take a line and draw it across California, where half of Californians would live south of that line and half would live north of that line, where would you guess it would be? It's actually the Burbank Airport, and half of Californians live south of the Burbank Airport. So when you talk about the average Californian, you're really talking about Orange County, San Diego, and LA, and that hides the real story of California, which is tremendous variation. Where some counties in our state have opioid overdose death rates higher than Ohio, which of course you read about in the paper all the time, and many parts of our state have much higher rates than the national average. Now, this map hides a really important, I think, beautiful story, which is Plumas County, tiny little county, less than 20,000 people. When we showed them this map in 2015, they were the worst county in California. They had the highest relative death rate in California. Now, statisticians will argue with less than 20,000, a few deaths will drive you up there, but it was a call to action. And the health officer got the community together, brought together law enforcement and the local medical society and public advocates and said, we have a problem. We're the worst death rate in the state and we have 0 opioid addiction treatment providers. The health officer himself got trained, Dr. Satterfield, to deliver addiction treatment or buprenorphine. They figured out how to do telehealth so you could get treatment in your iPhone. And the next year they had 0 prescription overdose deaths and went from being the worst state to the best state in the county. So data can be an incredible call to action. I think it's helpful to reflect, how did we get here? And the simple answer is overprescribing. We have tripled the level of opioid prescriptions compared to just a dozen years ago. And I trained in the era at the left side of that graph. And when I was a family practice doctor in training, we were taught emphatically, don't be scared of treating pain with opioids. Don't worry. There's no such thing as a ceiling dose. You can treat people with as many opioids as you want, including doses we'd previously only seen in hospice, and it's safe to do that. We were told these are not addictive if they're prescribed for chronic pain. We were told it's safe to give opioids a try. Just try it out, and if it doesn't work, you can always wean off. And we've learned as that graph escalated over time, as we flooded our community with opioids, that actually all these things were not true. They were imposed on us through misleading, false pharmaceutical advertising, quoting studies that don't exist, because in fact, tragically, opioids don't really make chronic pain better. In fact, many of us practicing in that era saw our patients get worse and worse and worse. The higher doses we prescribed, the worse their pain got. They got this all-over body pain that made their lives horrible, and that they only got better when they were able to be slowly tapered to lower doses. We actually learned that opioids are really hard to stop, that if you are one of those people gets minor surgery or tooth extraction and you actually take the 10 days of opioids that your doctor might give you, your chance is 1 in 5 that you'll still be on opioids 1 year later. We've learned that if you take opioids more than 3 days, every additional day increases your risk of long-term use by 1%. So we've learned it's not true that you can stop opioids and stop them easily. We've also learned that high doses are incredibly dangerous. Your death rate is 10 times as high on high doses as it is at low doses. And we've learned that these medications are addictive when taken as prescribed, that depending on the study, as high as 10 to 30% of people get addicted. So many family doctors like myself had a wake-up call. And mine was when I got a call from a coroner saying, as a courtesy, I'm letting you know that your patient died and your name was on the prescription bottle she was holding in her hands when she overdosed. Very painful news to receive. And to be honest, she wouldn't have died today if I was treating her today, because I would have been able to look her up in what's called the Cures database, which you'll learn about, and I would have been able to see an alert that she's getting medications from multiple providers. So even though technically I wasn't doing anything wrong, that practice of prescribing liberally is what got us to this problem. in the first place. And my clinic, like many clinics across the state and the country, completely changed how we treated pain. We started using opioids for far fewer reasons at much lower doses. We did the hard work of tapering people down. And many doctors like myself felt like if we were part of the problem, we should be part of the solution. So we learned to treat addiction in primary care, probably the best anti-burnout remedy we have because it was so satisfying. So of course, what created the overdose deaths, the more we prescribed, the higher the death rate became, and so it got us to where we are today. One of the things that I think is so important to understand is what happens to an addicted brain, because living with addiction is like living in a constant chaotic storm where every day is about survival. And what we've learned in the last 10 years is that long-term high-dose opioid use changes brain chemistry, sometimes permanently. And it turns out it doesn't matter if it's long-term high-dose opioid use from prescribed pills or from heroin, that the system in your brain that regulates your ability to organize yourself, the ability to make good decisions, to do things that are hard because they're good for you and avoid things that are bad for you but feel good at the time, all of this is regulated by a chemical called dopamine that gets absolutely destroyed by long-term use. So when you're living a life of addiction, your first dose of heroin makes you feel amazing. Your dopamine level goes 10 times normal, and then your brain immediately clamps it down. And you've probably heard this story that when you're addicted, you go from euphoria to euphoria, withdrawal, and pretty soon you're spending a lot of time in this withdrawal phase of where every cell in your body hurts, where you're sweating, diarrhea, and nausea, and you take the drug just to barely get up to normal. It gets harder and harder to move beyond normal to euphoria when you're caught in the cycle of addiction, exactly because of what happens to the chemistry in the brain. And that's why we've shifted our thinking to thinking of addiction as a brain disease, because opioid addiction, unlike many other addictions, is absolutely transformed by medications. We've learned that medications calm the brain chemistry, restore that dopamine access, and enable people to make hard choices, participate in recovery, change their lifestyle. And there are 3 FDA-approved medications for addiction treatment. There's hundreds of studies and decades of research on the first 2, methadone and buprenorphine, also called Suboxone. And these 2 are often called opioid replacement therapy because they act in your brain the same way other opioids do, but they stabilize your brain chemistry. They're long-acting. It's really hard to get that euphoria if these are prescribed correctly. And these are a game changer because without medications for opioid addiction, only 6 out of 100 people stay sober at a year. And with these medications, it goes up to 70% at a year, cutting mortality rates in half, cutting HIV and hepatitis rates in half, lowering recidivism, improving function in society. Naltrexone is been around for a long time in pill form, and although in pill form it is absolutely ineffective in opioid addiction, in fact increases mortality, in the injectable form called Vivitrol, it lasts a month and has been shown to improve outcomes in 3 to 6 month windows. What we don't yet know about Vivitrol is whether it ultimately changes mortality, because it's very hard to get on Vivitrol. Dropout rates are high, and we don't have data yet at 1 year. So we're still waiting to see how ultimately Vivitrol will compare to the other drugs. So what are we doing here in California? That's what this panel is about, and we're working in 3 main areas. One is to turn that prescribing habit around. So if we've tripled our prescribing rates, we need to dramatically cut them down while making sure that opioids are available at end of life and cancer and surgery. Certainly these are critical, helpful drugs, and we will continue to do harm if we go too far the other direction and make them unavailable. We have to go all out and make sure that addiction treatment is easier to get than street drugs. And right now that's not true. The big parts of California don't yet have an addiction treatment infrastructure, and people have to travel hundreds of miles. So until medication-assisted treatment, it's what we're calling MAT, a combination of medications and counseling, is widely available, we won't stop the death rate. And we have to make sure naloxone or Narcan is widely available. You've heard about this as the antidote for an overdose. It comes in spray or injectable form. And we won't stop the deaths until this is in the hands of every bystander who comes across someone who has overdosed. So we're starting to see improvements. It's a very great time in California because we're trending in all ways in the right direction. We're dropping opioid prescribing. We've dropped by 17% in the last 2 years. We're starting to see increases in addiction treatment access. Now, admittedly, buprenorphine or Suboxone is not the only answer for the opioid epidemic, and it's certainly not the only answer for all addictions, but it is the one thing we can track easily in our database, which I'll be sharing with you shortly. So we're using it as a marker of increased buprenorphine, as a marker of general addiction treatment access. And our number of deaths have been stable over the last 2 years, which is not a trivial accomplishment. These data come from this dashboard, and I highly recommend looking in your packet and going home and on your computer or your iPhone, going onto this website. You can get to it by Googling California Opioid Surveillance Dashboard. It is fantastic. If you're a little bit lazy and you want to just click a button, you can print reports that are beautifully designed, which show trends over time in ED visits, hospitalizations, prescriptions, and deaths by county and by state. And if you want to dig into the data, there is so much richness in this dashboard that you can come up with trends by age and ethnicity and race and even by zip code. So I strongly recommend that you do this. Beautifully put together by the California Department of Public Health and now being replicated in other states because it's that good. So a few comments about the efforts statewide, and then I'll be calling up the panelists to tell you about them in more detail. The California Department of Public Health in 2014 launched a statewide opioid safety work group, bringing together more than 24 state agencies to work in these areas we've discussed, prescribing, MAT, and naloxone, and also launching a major public education campaign, and of course creating the dashboard where we get all of our data. Healthcare Services has initiated 2 major statewide initiatives, both promising to transform addiction treatment landscape in California, not just for opioid addiction. The hub and spoke system is trying to replicate what we're very comfortable with on the medical side of things. If I have bad heart condition, I can go see a heart specialist, and when I'm stable, I can go back to my primary care doctor. And we need to develop that same thing in addiction treatment, where if you have more complicated addiction or you're just starting, you might go to a hub, which is a specialty opioid treatment program. Used to be called methadone clinics, now greatly expanding their services. And then stable people or people with milder conditions can be seen in primary care and other settings. For Medi-Cal, for low-income Californians, the Healthcare Services is creating an organized delivery system where across the state, organized through counties, all different types of addiction treatments are being made available to all low-income residents. So 40 counties have submitted their application and 7 are now live and seeing patients. Our Attorney General's Office, the Department of Justice, created Cures 2.0, another nationally recognized landmark database, because this database does 3 things incredibly well. It serves as a law enforcement tool to shut down pill mills, but more importantly, from my point of view, it allows me as a doctor to look at patients and be able to identify alerts for people at risk, and it provides the data to the dashboard so we can trend ourselves over time. Smart Care California was created by CalPERS, Medi-Cal, and Cover California coming together and using their influence to influence plans and providers, working in 3 main areas, including the opioid epidemic, also C-sections and low back pain, and we're going to hear more about that from our panel. And even though we don't have a panelist representing this, I do want to say a word about the Opioid Safety Network. When California Healthcare Foundation 2 years ago tried to look about how we can make a difference in this epidemic, we were struck that its culture is local. It is very difficult for doctors like me to change my behavior based on state guidelines. I'm much more influenced by my peers and the hospital environment and the culture we practice in. So San Diego and Marin had done amazing things by bringing coalitions together of law enforcement, public advocates, and hospitals. And they were able to influence our building of an entire statewide network. So now, 2 years later, we have over 35 counties that have local coalitions working together to tackle the epidemic. And we have an assessment now showing that it's working, that these coalitions really do make impact. You know, Sandra said this is the defining healthcare crisis of our time. I think we learned something by going back to the last time we had a similar health crisis. Population we blamed for their disease, we stigmatized people, we saw it as a moral failing, and death rates were rising seemingly without hope, and then they plummeted. for two reasons. One is medications were made available to turn HIV/AIDS from a death sentence to a chronic disease. And government agencies, public advocates, community organizations got together and said no one with HIV should die because they don't have access to these medications. They're made widely available. And we also worked on stigma so that someone with HIV looked a lot like us. Rock Hudson, Magic Johnson came out and it humanized the face of the disease. And that's, again, what we need to see in the opioid epidemic. One last word about lessons from other places. France had a similar problem, escalating death rates, and then they dropped their death rates by 80% in a couple years simply by making addiction treatment widely available. The government says we're not going to make doctors go through special training programs or have mandatory limits or have DEA come visit them. We're going to make insurance companies pay more for doctors to treat addiction in primary care. As a result, buprenorphine was made widely available, and unlike us that continues to rise, they dropped their death rate. So again, something to learn from. We do have reason to be concerned about fentanyl. Our rates of fentanyl deaths are rising, and this is a drug that's used in cancer and advanced pain, but when used on the street is incredibly potent, incredibly dangerous, 100 times more potent than morphine, and so this is something we're really concerned about and keeping an eye on. So in summary, this is a hard, complex problem to solve, and we need to systematically work across our state, and that's what we're going to be talking about today. We need to work on prevention, using opioids for far fewer conditions, and working in communities and schools to change how people think about the safety of opioids. We need to identify the people at highest risk of death who have chronic pain, and rather than just going 180 degrees and cutting everyone off opioids, we need to identify those people at risk and help doctors work with them to taper to lower doses and not and make sure that opioids stay available for those who need them. We need to streamline access to treatment so addiction treatment's easier to access than street drugs, and stop the deaths with Narcan until we get to that point. So now I'm going to invite up my panelists, if you could come on up, and we're going to start our panel discussion. We've got Dr. Karen Smith, our health officer, leads our public health department. Jennifer Kent, who leads healthcare services. Lance Lang, representing SmartCare California. He's a family physician as well. And Tina Ferrales, who directs the CARES program. So come on up and give him a round of applause, and we'll get started. So, Karen, if you would kick us off, tell us a little bit more about the work group. What's it doing and what's it accomplished so far?
Thank you, Kelly, very much. Well, I think in terms of our accomplishments, you've talked about some of them. We're happy to claim the decrease in prescriptions and the stabilization of the death rates as a state. I think the most important thing about the work group is what it represents, which is government doing business differently. We are a very broad now organization. This work group of 22 separate departments and agencies across the government, across the entire administration, with now partners from the federal government and the DEA as a partner, as well as the nonprofit community. California Healthcare Foundation was the first external partner, and also representation from the local level. And the goal of the work group really is to have a set of common goals and aligned activities. So each entity does its own thing. We work at CDPH in our lane, Jen works in her lane, Lance works in his lane. But what we're all doing is we're actually having mutually aligned activities that reinforce each other. And that has really changed things in that we are each able to leverage that partnership. One of the first and most important accomplishments of the work group is that by including this description of the work group and the work that we're doing, we've been able to leverage that and get almost $50 million in federal funding coming into the state, because we were able to assure the funders that we would be able to come through with what we said, because it's not just one department taking on this huge and complicated problem. And that's in addition to the funding for the hub and spoke model that Jen will be talking about a little bit. So that has allowed us to do a lot of other work. In the realm of the safe prescribing practices, which is a big part of the work that we've been doing, the work group has focused largely on physician and pharmacists, both outreach with guidelines and et cetera, but also education and actual training. So one of the first things that happened in 2014, the Medical Board of California was one of the first organizations in the United States to put out treatment guidelines. And the work group continues, the partners continue to push out those guidelines along with the Centers for Disease Control guidelines and really actually provide materials that help physicians understand how to put those in practice and to prescribe more safely. We also, I'm going to just say we for the work group, each of these is different partners working, but either individually or in collaboration. But we've developed a curriculum for pharmacists on naloxone and how to dispense naloxone. We put out a very detailed healthcare provider newsletter that gave links to really robust resources for physicians like Kelly used to be, who are trying to take care of these patients, trying to get them off the medications. These are very difficult conversations, and not every physician knows how to do that or where to reach out for help, and so we've provided that. We're also doing academic detailing. We've developed a curriculum where local jurisdictions can have folks go in and have one-on-one training conversations with physicians about the dangers of opioid, about how to help provide resources to get folks off of these incredibly dangerous drugs. In addition to that, we've been promoting cures, which you'll hear more about as well, throughout the state to make sure that providers know that there's a requirement to use cures, but also the value that it has to them. It's not just the Department of Justice looking over their prescribing practices, but rather an incredibly useful tool for them. We've also managed to increase the access to naloxone across the state to actually save lives. And this initially happened when the Board of Pharmacy changed their regulations to allow pharmacists to actually dispense naloxone without a prescription. And that was huge and really increased access dramatically. In addition to that, pharmacies are now able to create drug take-back programs, which, while not increasing access to naloxone, decreases deaths by keeping some of those drugs from getting out into the illicit market. We also have a naloxone distribution grant program from the state of California for a one-time $3 million to purchase naloxone, which we're then distributing out to local health jurisdictions and their partners to get to first responders and others who can really, on the street, use this drug to save lives. And the first shipments, I'm happy to say, are going out this week. So, and a big focus of the work group has been on providing support to the local opioid safety coalitions. These are coalitions that, like the state work group, are multi-sector, so bringing together a lot of not usual partners to work on strategic planning, policy development for how to get the healthcare system to use opioids safely, and how to, while at the same time recognizing the need for appropriate pain control, supporting expanding medication-assisted treatment, increasing access to naloxone, and also really making sure that the public understands the dangers of opioids and how to safely dispose of them. Another big accomplishment we feel is the opioid dashboard, which you spoke really eloquently about. The intent of the dashboard, and I do recommend you look at it, is to provide actionable data, not just data for nice graphs, but data where if you're working in a local jurisdiction or even at the state level, we have numbers that help us decide how to make decisions. And then finally, really briefly, we're doing a lot of public education. We're about to launch a really detailed and expansive awareness campaign on the risks of opioids, but at least as importantly, working to decrease stigma of addiction therapy.
So thank you, Karen. Anyone who's worked in government knows it's not a trivial thing to get 24 agencies across all branches of government coordinating their activities. This has gotten a lot of work in a short period of time. So Jennifer Kent, also speaking of big lifts, you've got two major initiatives in your area, hub and spoke system and drug Medi-Cal. Can you, the map behind you lays them out. Could you tell us a bit about those programs?
Sure. So I think I'll start with the organized delivery system. Prior to my work at the department, under the previous director, there was a really unfortunate national news story involving some of our Medi-Cal providers, specifically in the drug Medi-Cal program. It was not a high point of anyone's career. But I think what we learned from that is out of really bad, unfortunate situations that could be embarrassing to be in at the moment, what it led us to was to develop an amendment to our 1115 Medicaid waiver, where we went to the federal government and said, we need to reorganize this delivery system. We actually need to organize it, not reorganize it. We just need to organize it. And we want to work with our counties to provide a full spectrum of substance use treatment for individuals, and not just obviously for opioids, but for all forms of substance abuse. And so really what that did was set up a system in the state. We are the first in the nation where we're providing care through the counties at their option. They have to voluntarily opt in to be a waiver county. And this is from residential treatment and detox in an inpatient setting all the way down to outpatient therapy, sober living environments, medication-assisted treatment. And so what we are in the process of implementing is we have 7 counties that are live and have been delivering services in varying times through 2017, including the great state of Los Angeles, as they would like to think of themselves. But obviously, when you have 40% of the state's population and you step up and say, we need to be able to do something for our county residents, the fact that LA came on and they came in early is really significant. We have another 8 counties that are going to be going live either at the very end of this year or the beginning of next year. And then we have 40 counties that have raised their hand and said, we want to participate and provide services to our residents. And so we're in the process, and if state government agencies cooperating with each other is any difficulty, you can only imagine when you put locals and the state and the feds in the room all together. It's just a real, it's a party. And so it takes a while, but I think when we have, upwards of 40 counties out of 58 saying there's something that we want to be able to do, working with our local providers, working with our various treatment facilities, it's going to, I think, be one of those things that will be a model for the rest of the country. And I get calls and emails regularly because I'm the point of contact for the SAMHSA block grant. So I will get emails. I got 4 or 5 over the weekend from just people that are surfing around the internet looking for treatment for their son or their daughter, themselves, their wife, their husband, their brother. And so it's actually nice to be able to respond and say, there is something that can be done. There is a place that you can go. And these counties are really stepping up, and I have to give them credit. It's really hard to change what you have done in the past. We have contracts that have been through, I can't tell you how many layers of scrutiny between us and the federal government. They have to be voted on by the boards of supervisors. They have to go out and do contracting with various facilities and providers that they've never done work for or work with before. And yet, they are in the trenches helping us achieve what I think, again, came out of a very bad situation, but we think will ultimately be to the benefit of our beneficiaries in the state as well as to the rest of the nation as a whole. Shifting gears to the hub and spoke model, same thing. There was an opportunity at the federal level around opioid medication-assisted treatment, and it was a non-competitive grant. So again, all we had to do was fill out one of those oh-so-simple applications, and it's 2 years, $90 million. But just as Kelly indicated on her slides, there are counties in the state that look a lot like states in the nation with the highest overdose rates, and that's not something that we are proud of. And I think that what we also know is that it's easier said than done to change local opinion or local practice when it comes to locating narcotic treatment providers in some of those areas. And so your high northern counties have much higher overdose rates. And so we went to the federal government and said, for this $90 million grant over 2 years, we want to focus not only on some of our highest overdose rate counties, but we also want to work with our tribal community. In California, we have a lot of Native American tribes that are suffering at rates that are far higher. And so both in our 1115 waiver and the organized delivery system, as well as in the Cures Act, we've had specific provisions relating to the tribal community because of the differential rates of overdose and death in those particular communities. Through the hub and spoke model, we've awarded 19 grants And really what these hubs serve as areas of expertise, both clinical and programmatic expertise, where they work with spokes, meaning primary care providers, FQHCs, providers in the community, where we are helping them get comfortable around treating people in primary care settings with substance use disorder, using buprenorphine and other medication-assisted treatment. If a patient's complexity changes in terms of their clinical complexity, they have someone that they can call and say, I'm struggling, or can I please refer this patient to you, where you can work with them more directly and then put them back out into the community for regular treatment. These hub and spoke systems will treat upwards of about 24,000 patients, we estimate, in the next 2 years, and it involves 34 different counties, 7 of which are in the top 10 overdose rates in the state. And so I think we have a lot of optimism around putting that money out the door, changing some of those local patterns of behavior. But I think also we know that we can't build enough treatment beds in the state of California. We can't graduate enough clinical experts to be addiction specialists. And so we look at this money as an opportunity to help build some local expertise and comfort in treating this, because this is a disease that is not going to be able to be completely isolated into the addiction specialty area. And so we're going to have to work with providers on the ground to have them be more familiar and more comfortable in how they prescribe and treat individuals, not only on the prevention side, but also once there's a problem that they can work with the individual on their addiction issues. So I will stop there and then happy to take questions later on. Thank you.
Well, thank you so much. And a call out to Marlise Perez and her mighty team, which is lifting up these 2 huge projects. So Lance Lang, I mentioned before that doctors are very difficult to change and health plans aren't so easy either. So can you tell us how Smart Care California is tackling the opioid epidemic and what your approach has been?
Well, thanks. It's great to be part of this august panel and to work with all of you. I can't help but start out by noting that it's really important that California's worked so hard to implement the Affordable Care Act, and that we've lowered the uninsured rate from 17% to 6.8 early this year, and that under that insurance is no longer junk insurance. It includes substance abuse treatment as an essential health benefit, at least as of this week. As of today, yeah. So, I mean, really, that's really a big deal. So that what we're talking about for most people is now covered, and that's a really critical thing. Second, I've had to go to school on this stuff, partly just because it's been a while since I was a real doctor, but more because I had to undo the training that, just like Kelly described. When I practiced in Seattle, but when I moved to California, one of the first things I had to do was take a medical board required course that followed the outlines that Kelly described, which basically shamed me into saying I was underusing opioids. And it's done, that was required by the medical board, a full day. So part of what we've been doing is catching up. Partly is what we're doing is unlearning what we were forcibly taught. So what's Smart Care? Smart Care California is another one of those unlikely collaborations. It's all the state purchasers of California leading a multi-stakeholder effort. Multi-stakeholder in the sense that there are consumers, physicians, physician groups, hospitals, health plans, and purchasers all working together to solve problems around overuse. And we went through a prioritization process to figure out what we should look at. And first kind of wrestled with, so what is this overuse thing? It's about variation in practice. What leads to variation in practice that can be measured both across geographies and within geographies or within physician groups. And it's about poor understanding of best practices, somewhat promulgated forcibly. and that misunderstanding is both by providers and consumers. It's about a lack of system to support best care, and it's about too many priorities. There's so many things to fix, and there's so many different purchasers out there saying this is what's most important. If DHCS and Cover California and CalPERS, with participation with PBGH, the Pacific Business Group on Health, can all agree on common priorities, then we increase the chances of success. So we used Choosing Wisely from the Board of Internal Medicine Foundation, which brought all specialty societies together, and they each chose 5 things within their specialty that they knew were overused, that they had some value for some select patients, but they were being used outside their indication. And we heard from places like Cedars-Sinai that it taken all 500 of these overused things and put them in their electronic health record as alerts. And that was pretty impressive, but we realized that that was more about their IT solution and their culture of being willing to put up with all those alerts than it was about the complexity of individual problems. And so our group decided to focus on 3 problems around which to provide that focus to our provider community and say, these are important. And in that process, it was hard to ignore opioids. We went through a prioritization process that it's the usual sort of thing. So we're a big tribute to CHCF in their guidance. Smart Care also has the luck of the funding from California Healthcare Foundation, not only for convening and bringing people together, but as thought leadership. And they've provided Kelly as a part of our work group. They recently published, and I recommend to you, a great white paper on what health plans should do around medication-assisted therapy. It's a great guide for any of us, and really goes into great background. We've not coincidentally, therefore, Kelly's slide on the 4 things that we should focus on are the 4 things we're focusing on. We take direction pretty well. So reducing new starts, especially given what we know. How many of us have been to the dentist to get our wisdom teeth out, and we get a huge bottle of opioids that we may or may not finish, but to learn that if you stay on it more than 3 days, your chances of not getting off rise. I don't think very many of those prescribers know that. So we've been looking at things like having no how do you provide alternative? Oh, I'm out of time. But I'll follow good examples and just go 1 minute over to say that we're looking at prior auth for alternatives to pain management. We're limiting the quantity used and putting in a prior auth for any refills. We're looking at how to manage pain more safely, which is to identify patients with chronic pain, to offer them alternative treatments, to decrease the number of patients on high dose of treatment, and to avoid concurrent opioids with benzodiazepines. Treating addiction better includes taking prior auth off MAT treatments. It includes taking advantage of the network of the hub and spoke types of processes, which takes advantage of the systems that we have in place and really analyze our networks. And finally, we need to stop overdose deaths, which includes things like taking prior auth off naloxone, and we'll maybe describe some other things later in the Q&A when I'm not past my deadline. I'll pass.
Thank you, Lance, and I really appreciate that perspective. Now, Tina directs the CURES program, and as we all know, large amounts of data does not mean information, and that's what CURES is nationally known for, is taking massive amounts of data and making it practical and useful. So tell us a bit about CURES, and especially about the impact of AB 40, which is working on integration with healthcare records.
Sure. Good morning, everyone. CURES is California's Prescription Drug Monitoring Program, or PDMP. CURES stands for Controlled Substance Utilization Review and Evaluation System. I've said that a billion times. But anyway, CURES is our PDMP. And what essentially CURES is a repository of all reported dispensed prescriptions for Schedule 2 to 4 controlled substances. So by law, all pharmacies and dispensers licensed in California are required to report when they dispense a prescription to a patient that's a Schedule 2 to 4. All of that data basically lives in the CURES 2.0 system. So we make this CURES 2.0 available to law enforcement and regulatory agencies, as well as to the providers. So you can imagine how valuable that information is for all of those types of clients. Kelly mentioned that we have a lot of data. Yes, we are probably the largest state in terms of volume of prescription records that we receive for Schedule 2 to 4. We receive about 1 million prescription records a week. On a daily basis, we get about 165,000 prescription records each day, give or take. So we do have a lot of data there, and as a provider, one of the big advantages of utilizing CURES is that you will see prescription data dispensed to your patients that are not only within your healthcare system, but that were dispensed from various different healthcare systems and providers and dispensers throughout the state. So you get kind of more expanded view of your patient's prescription history when you refer to your patient's prescription records via CURES. So that is CURES in a nutshell. And Kelly, you mentioned Assembly Bill 40. For those of you who aren't familiar with AB 40, that is a new law that was chaptered on October 9th, and that basically provides DOJ the authority to make CURES data available via integration. Presently, right now, we're only allowed to make CURES data available through our website, through our web portal. So as long as you have a computer and current web browsers and on your laptop or computer, you can access CURES via the web, via internet. AB 40 now, what this allows is for DOJ to make the CURES data available through integration, meaning if you are at a facility and you have access to your facility's electronic medical record or electronic health record, this allows for integration through your EHR. So that is a big, that's somewhat of a game changer in terms of accessibility to CURES data for the providers. Quite honestly, we weren't able to do that. We didn't have something like AB 40 that authorized us to do that, but now that we have AB 40 just chaptered, we have probably within about a year or so, you'll be able to see integration of CURES data in electronic health records. Now, in order for us to integrate with a health entity, that health entity or health IT system needs to be able to say that they meet technical and security requirements for CURES data. So as long as that health entity that sponsors that IT system can enter a memorandum of understanding with the Department of Justice stating that they meet all of those requirements, then we can start doing that integration process. So like I said, this bill was chaptered very recently. We're still in the early stages of building out the technical aspects of making this a reality, but we're forging ahead with that new requirement, and we're excited about the results and making this valuable CURES data available without you having to hop off to the internet and logging out of your EHR. So we're looking forward to that.
Well, thank you, Tina. Like I said, this is a life-saving tool, and I do think my patient would have survived if this information had been integrated in my electronic health record, and I could see that what I was dealing with was addiction and not low back pain. I'm going to be teeing up a few questions, and then we'll open it up to our audience. I'm counting on my team to let me know when we need to switch gears. But Karen, I was wondering if you could start talking about fentanyl. We talked about the threat of fentanyl. Tell us a little bit about that and what's being done.
So fentanyl is like the other opioid, most of the other opioids, it's actually a legitimate, useful opioid medication. For the longest time, it was used primarily for severe pain, cancer patients, et cetera. It can be used in a patch form, and which can provide a nice, slow release over a long period of time. Recently, however, synthetic fentanyl has been flowing into the United States through the illicit market. Per my DEA colleagues, most of this material is actually manufactured in China and then comes up to the United States through the U.S.-Mexico border at various places. The thing about fentanyl is it's much, much more potent in its native state than are most of the other opioids, your Vicodins, your Percodins, which are probably the ones that you're most familiar with. Increasingly, as with all providers of substances, they're getting better at making more powerful. There's a new drug, well, at this point it's not terribly new, carfentanil, which is almost 1,000 times more potent than your basic opioid. And what that means is that very small amounts can kill you. And these drugs are coming into the U.S. Disguised as your average, if you will, street drug, Norco, the most common. And what's happened is we're seeing clusters of deaths from fentanyl. People who are buying their street drug the way that they normally would, and what they're getting instead is a pill that's 1,000 times more potent, without any knowledge of that happening. And so it's become extremely dangerous, and we're seeing more and more deaths. That's the one area where I think our trends in California are not what we'd like to see. While we're decreasing the overall dosage of prescription drugs, we're actually increasing heroin, and we're increasing the fentanyl deaths as well. And it's difficult because overdose deaths are not always pursued in terms of actually what drug was it that this person took. And so we're actually working hard with coroners and others to try to make sure that when there is an overdose death, that they actually test for all the different drugs that are available, including the fentanyl drugs. And we're developing right now a fentanyl death indicator that we'll be adding in the near future to the opioid dashboard.
Fantastic. To follow up, Jennifer, on your comments, these are two really big programs and quite different. One working on all addiction treatment for low-income Californians, and hub and spoke focused just on MAT. How are they reinforcing each other so we get to that place where MAT is accessible for all?
I think, first off, I think that given the fact that a lot of people are paying attention to the opioid epidemic right now, a lot of people have thought of the organized delivery system as being primarily around opioids, but it's not. I think, a lot of us that have worked in the Medicaid arena for a long time have been aware of a complete lack of services for a lot of different addiction issues. But I think the fact that you have counties that are rolling out their organized delivery system program and their services, the fact that there's such a heightened awareness of the opioid epidemic at this kind of point in time, then you couple that with the Cures Act funding that is really targeted at getting at some counties that may or may not be able to do an organized delivery system the way that we are thinking of it. There's 8 counties that are working with one of our county organized health systems because they're very, very small. So these are your top northern ones. And I'm going to get them all wrong, but MODOC is one of them. MODOC is never going to be able to roll out its own full spectrum comprehensive delivery system because it's MODOC County and there's not enough capacity to build all of those various pieces. But I think the Cures Act funding will first off really try to embed some of those providers and services and familiarity with MAT in counties where there has not been ever. But then I think it will also then allow us to have a conversation, especially with the 40 counties that are rolling out the ODS waiver, to say, did the MAT money through Cures actually help you in your communities, or vice versa? They're going to hear from counties that are like, oh my gosh, we've been a part of this waiver amendment where we're able to provide this full spectrum of services. And MAT is one of those components, but I think that's how they're going to both complement as well as incentivize some of those counties to, if they're not using one, they'll use the other. If they're using both, they'll be able to provide like a living, breathing example to other counties that may not be able to do anything at this point in time or have chosen not to. And we do have some of those counties.
That's fantastic, because addiction is not new, and we've had large populations damaged by addiction. We've been in the habit of doing wars on addiction and criminalization, and so it's important that we take the advantage of all of this attention on opioids to make sure we build a structure that provides treatment no matter what your addiction is, including those, like I mentioned, that kill far more people. So Lance, let's talk a little bit about naloxone. We know that there's many ways of getting naloxone into the community. Getting doctors like myself to prescribe it at the same time we prescribe opioids, getting it in the hands of people in needle exchanges and community organizations, and even getting pharmacists to prescribe without a prescription, which is now illegal in California. How is SmartCare approaching this to make sure that naloxone is available whenever it's needed?
Well, we have several levers. We're purchasers working with the rest of the delivery system, and I think the first step is around benefit design. And at Cover California, we've really been pushing the notion of standardization. And what's cool about SmartCare is it's a collaboration among the purchasers, looking at not just at how we can align. And, Cover California renews their contracts regularly. DHCS is in a process for the first time in, is it 20 years, in going out to bid and thinking through their contract structure. CalPERS is restructuring, and we've been talking with PBGH about creating model contract elements. So things like making sure substance abuse is recognized as an essential health benefit no matter what happens in Washington. Looking at barriers in terms of cost share. All that builds into the benefit design. MAT in some states no longer has a cost share, and that includes naloxone. Looking at alternatives to care is another, besides naloxone. It's really inexpensive for a single copay to get a narcotic, but PT is which is often
physical therapy
visits, is a copay for every visit. So we've been asking the 11 plans who work with us, is how is it possible to implement a bundle for a single copay? And if our plans say so, then that's something we could bring to SmartCare. I think that you want an evidence-based formulary. So if benefit design is first, is what's on your formulary, and through SmartCare, we've been querying our health plans, and that's turned into an intervention, in fact, just by letting them know what national standards are, and we've either induced or supported trends that were already happening to make sure that buprenorphine and naloxone were available on every formulary. I think that covers my time. But.
Thank you. Well, Dina, you were just saved by the bell because it is time to switch to our audience questions.
Thank you. My name is Glenn Backus. I work with Drug Policy Alliance and other health groups. Seeing as addicted people are overrepresented in jails and prisons, does anyone on the panel or in follow-up from Healthcare Foundation want to comment on availability of MAT or naloxone in jails or prisons?
Sure.
So I don't have detail. I do know that, and actually we have an expert in the audience, but I do know that the California Department of Corrections and Rehabilitation actually is implementing a very large expansion of the availability of medically assisted therapy throughout, ultimately throughout the entire system. At the moment, I believe they're working in 2 separate facilities. So there's a lot of attention being paid to that right now.
And again, getting back to Los Angeles doing everything, even though they're massive, they've got a big project right now to make sure all 3 forms of medication-assisted treatment are available to all inmates. And it's a really big lift. It's a tough thing to solve. But we brought that LA team out to go visit Rikers Jail in New York City and Rhode Island Department of Corrections that's been doing this for a while, because Rhode Island realized that a quarter of their overdose deaths were people within 30 days of release from jail. And they had to wake up to the fact that if you jail someone for an addiction, you're automatically increasing their mortality. And it's our obligation to do something about that. Next. How about one?
I'm Gina Anderson, Eldorado Community Health Center. So I guess my biggest question is, we talk about alternate treatment methods, especially for pain management, as many of these folks have become dependent or addicted to opiates because they were an injury or surgery or something. What are giving access to opiate treatment? I talked about we have some access for acupuncture, massage, but it's incredibly difficult labor intensive process to get like prior auth and approval through insurance and something like full injection and other modalities that really could be helpful.
So I don't know if you want to tackle them from Medi-Cal, because Medi-Cal has the advantage of already having acupuncture and chiropractic as a benefit, and in some ways community health centers may be leading the way in getting more complementary therapies.
Sure. I mean, I can try, and her microphone wasn't on, so I'll repeat the question in a shorter form for those of you that couldn't hear. It was essentially what's being done to offer and provide alternative treatments to individuals in lieu of opioids for pain or chronic pain. I think within Medi-Cal, we have a standardized set of contractual requirements. They're not 20 years old, Lance, but our health plans work under contracts, and we do regular kind of updates. And so as the benefit changes within Medi-Cal, most recently around the imposition of mild to moderate treatment for mental health conditions for plans, which was done in 2014. There are ways in which we can work with our health plans. We have 23 contracting plans. We have approximately 10.5 to 11 million individuals enrolled in managed care. So those are ways in which we can have plans provide both standardized benefits. We have clear contractual requirements. They are allowed to go beyond what we mandatorily require as a minimum. So we have been working obviously around prescribing patterns and opioid use, and trying to have them be aware of the fact that they themselves also need to be aware of what their providers are prescribing. I think we have a group of medical officers that we meet with regularly. You used to be one, Kelly, where we bring certain topics to the health plans and to the clinicians that are leading the plans and saying, how can we either do this better or how do we implement a certain program? I think we've had several conversations around opioid use and alternatives. Acupuncture was recently restored by the legislature as a mandatory benefit in Medicaid. So this is for both managed care as well as in the fee-for-service system. So we have different places in which we can offer benefits. We don't necessarily lean in terms of, we don't incentivize certain things, and other alternatives such as I thought I heard you say joint injections. A physician can prescribe anything for a Medicaid beneficiary as long as it meets medical necessity. It doesn't necessarily mean that we will approve it. They can prescribe it. If it's a health plan that is responsible for that entity or for that individual, the health plan would authorize the service. If it's an individual that's enrolled in fee-for-service, it depends on the benefit. It depends on whether they meet medical necessity. It depends on whether or not we have a treatment authorization requirement in that. So for acupuncture, I think up to 6 visits we allow, and then after that, subsequent, there's a limitation on the numbers. But I think to the extent that there are acceptable alternatives, we will obviously make those available, but we won't necessarily prioritize them or offer them in alternative. We try really hard not to do kind of preferential benefit design. That being said, I know that we do step therapy when it comes to certain prescriptions and use patterns, but not necessarily one benefit over another.
Fantastic. Karen?
Yeah, I just wanted to add, it isn't, the issue isn't just the authorization, it's also a lack of good scientific data to say what works best and for whom. because each individual patient is different and responds differently. The other thing is there is a very real shortage of pain management expertise, and that's particularly true in rural areas, because to really help someone with chronic pain, you have to actually assess that individual, and that takes time, and you have to try various and assorted things. So I think it's a combination of things, and increasing that capacity is, I think, going to be very important.
So let me talk about the other end of the spectrum, which is early after an injury. And there's an issue of speed. How fast can people be seen? A typical primary care office has a 6-week backlog. If a patient who's injured themselves sits at home hurting, without an alternative, no matter what's available, they're going to get angry, they're going to get frustrated, they're going to perhaps be prescribed opioids over the phone. So that's where the system of care issue in terms of team-based care in the office, the new models of primary care, patient-centered medical home or health home, where you do today's work today, which is you see someone within 24 hours. So one of the cool things about Smart Care is we've got both CMA and CAPG and the hospitals in the room to talk through how can we pilot some of these ways to get care quickly. And then docs are going to have to get comfortable using chiropractic and acupuncture in addition to PT, and we need to look at benefits. But speed is key. And right now, even if you know the best approach, even if those services are covered, if patients are sitting at home for weeks waiting for care, you're behind before you start.
Again, a big problem to solve, but until it's easier to get safe pain treatment than it is to get opioids, we're going to continue to get stuck. Who's next?
Hi, Lindsay Peterson from Covered California. And my question's about naloxone availability without a prescription. And I was just wondering if that's available at all pharmacies or just some, and approximately how much that would cost somebody.
Yeah, the challenge is that a naloxone can be furnished by a pharmacist without a prescription, but not all pharmacies are doing this. It takes extra time. I think there's some concern about our pharmacists adequately reimbursed. So even though this is legal, we haven't seen a lot of pharmacists pick this up. And so the cost is a real concern. I think the cost for self-pay might be around $75. So it's actually a lot cheaper for people generally if they have insurance or Medi-Cal to get a prescription for it or to get it dispensed like in a community setting like the what Dr. Smith was talking about getting the naloxone out into the communities than it is to do this pharmacy furnishing. So we still have a ways to go. Next.
I would just say Medi-Cal covers both naloxone and buprenorphine without tar on the fee-for-service side. And I believe I'd have to double check that we will cover naloxone also not only to the Medi-Cal beneficiary but to a family member. So we have, and that has been in place for a long time. It's not a new thing for us. And so those are no cost for a Medi-Cal beneficiary.
Yeah, and Medi-Cal's been very forward-thinking in that. Who's next? Go ahead.
David Panish, California Health Policy Strategies. I'd be curious what the view was about the bifurcation that we have or the carve-outs in the Medi-Cal system for drug treatment versus what we have on the Covered California side or on the commercial side where it's more unified. So if someone is going to a primary care physician and they have commercial or Covered California coverage, and they're identified as having an addiction, what kinds of things can the primary care doc do or the clinic do to address that versus on the Medi-Cal side where they might have to be referred off to the carved out program?
So to clarify, just because something's carved out financially, it doesn't always mean that it's not available co-located. I don't know which one of you want to tackle the question about, you want to start with commercial and then we'll go from there?
I don't think it's better under commercial insurance. And I don't have a pat answer or a complete answer. The financial separation, which is has caused some perverse impacts due to the parity laws that confuse people about who's on point and create some barriers to share care. And I think it's the new efforts which they're new in their acceleration. They go back to the mid-90s. I actually got to practice in an environment where we integrated, and it was terrific, but that's rare. And I think integrating primary care with behavioral health writ large, including substance abuse, is a high priority for all of us, and I don't think there's anyone who's got it well managed right now. Broadly, I mean, there are great pockets of examples of what we can stretch for, but I think we have a lot more work to do.
In your presentation, you talked about other countries having led the way in certain areas in reducing overdose deaths. I think you mentioned France. Some of the ways that other countries have led the way is also in implementing supervised injection services, which are places where injection drug users can inject drugs under the supervision and care of providers, of nurses and peer counselors, and have early access and easy access to other kinds of care. I'm wondering if you could talk about that, some of the research around that, and the impact that's had on both reducing overdose deaths and also on helping high users access care.
So you're bringing up the question of harm reduction, where in a perfect society, every person with addiction would get treatment. And in the society we live in, sometimes keeping people alive long enough until they can pursue treatment means things like supervised injection sites and safe houses. So I wonder if any of you want to take that on in terms of
Well, what I will say is there are places in California that are very interested in doing this. There are lots of issues about legality and exactly sort of procedurally how that'll work. But as you point out, there's really good evidence that it can work. I think there's a huge stigma issue that remains as well.
Yeah, it's interesting. I mean, things like needle exchange and even naloxone distribution used to be in that same category of illegal things that people did anyway because they were the right things to do, and over time the laws changed. Right now, I couldn't possibly predict what's going to happen with state and federal law on that issue, but it continues to be discussed.
Thank you. Bryce Doherty with KP Public Affairs. And a lot of discussion, a lot of research on managing chronic pain, pain management. Any comments on, maybe this is an opportunity for you, Dr. Lang, to elaborate on your preventative comments, but any look that the foundation or the interagency work group is looking at for preventing dependency in the first place, particularly in the outpatient surgical environment or in the acute care setting, where there are alternatives to opioid prescribing, whether that's a bupivacaine-based, long-acting local analgesic that lasts 24 to 36 hours. A lot of discussion around preventing opioid addiction and dependency in the first place, particularly in those post-surgical acute pain environments.
Well, there's two kinds of prevention. One is, stopping use before it even starts, the work that your department's doing in schools and communities, and the other is doctors like us treating pain differently, not starting that path. I wonder if any of you want to tackle either one.
Well, I don't know a whole lot about the studies that you're talking about regarding the actual analgesic alternatives. I will say, though, that as we have raised the profile of opioids and made the general public much more aware of the risks of starting on opioids, this has led to a shift in patients pushing back on getting, huge prescriptions for opioids after a simple surgery or even a more complex surgery, where really that 3 to 5 days is absolutely as much as you need. So we've been focused largely on cutting prescriptions down to that very short number, but I think that the more we push, the better it'll be in terms of really good alternatives, but I'm not an expert on those.
Yeah, I think the trend toward tracking for, setting limits on the number of pills in the initial prescription, putting prior auth on refills. I think you're citing alternatives even right during surgery to have a opioid-free period during the first 24 to 36 hours is all great stuff, and I'm encouraged by the trends in that regard. I think, but we have a long way to go. My daughter just had a baby and had a C-section. She went into her doc. Well, first at discharge, which was on day 3, she asked about getting off, and doc said, "Nah, it's too early," and wanted her to be able to be mobile, and told her. And then she was off at the 1-week check, and the doc wanted her to go back on, saying, this is. There's a lot of education to be done across the board. You can be mobile without opioids a week post-surgery.
And in what Lance had mentioned is a lot of physicians are having to undo decades of learning where we thought it was safe. So we have time for one brief question, so if you can.
I'll be very brief. Kathy Jett, private consultant with criminal justice predominantly. And I'm glad, Kelly, that you're going into the LA County jails. One thing I would encourage the panel to consider. Voluntarily, right. Yeah, I forgot that. I'd encourage you to look at is bringing the medications behind the wall before people leave. And we've had some success in LA County in doing that with one medication. You'll find, and I hope this will help inform the system, that you need to do it even longer. Short, like 2 months, maybe 3 months, because of the AB 109 cycle. It changes people's release date. So a lot of times we have people ready to go on medication, and then they get released and we lose them. And it's much, much more difficult to catch them in the community. It's much easier behind the walls. So I encourage you to look at that, and particularly in the hub and spoke, because you have some latitude there.
And I'm glad you bring that up, because people with addiction hit many places. They hit primary care sites and emergency departments and hospitals and jails and treatment centers. And these organizations, these state agencies are working with statewide leaders to create every door is the right door system of care. So ultimately, 10 years from now, we aren't looking at these kinds of disparities where you happen to be, whether it's a jail or a primary care site or a hospital, determines which of the effective treatments is available for you. So we have a long way to go, but I'm very proud to be a Californian and proud to be working with these organizations, because we are making fantastic progress in a very complex state. So I thank you for your time. It's been a great afternoon. Please do fill out your evaluations. They're helpful to us. And there is lunch available. We wish we could have given it to you here, but if you grab it, it'll be out the door. So thank you so much, and a round of applause for our panelists.